Some of the drugs will help with that, some of them will worsen them. So some is looking at what is their predominant symptom, what is the predominant disability, and focusing the drugs that way. We're treating symptoms. We do not know what causes it, so our ability to treat cause is not available at this point. Maybe someday that people will figure out what is causing it. They do better with individualized approach in terms of what is wrong, what needs to be done, and the other is they need multidisciplinary. So multiple people, cognitive behavioral therapy, maybe people are psychology, disease, more specific disease or comorbid disease related folks. And I think it also helps to spread when you have a indeterminate disease. More people's input usually helps, and it doesn't wear one group out over the other. Okay, so patient education. Education is shown to be effective. Telling people, here's what you have, here's what it, people usually do better with the known than the unknown. And so helping them to understand that. So there's different types of education that have been looked at. Do you put them in a small group? Do you do individualized? Do you give them information to read? All of that seems to be helpful. Sessions probably better, multiple sessions to help them work through it and understand. People who do that tend to improve better and have less pain, sleep, fatigue, more self-efficacy. Sleep, so good hygiene, like we have talked about already, emphasizing that, and then addressing specific causes or comorbidities that can be worsening their sleep. When you all know this, when you don't sleep, nothing looks good, right? Doesn't a good night's sleep always make everything look better? Yes, makes Monday look better. Okay, reassurance, it is a real disease. Making sure that everything else has been ruled out. So sometimes it comes down to a disease of exclusion or a diagnosis of exclusion. Role of stress and mood disorders, so relaxation tends to help. Stress, avoiding triggers, someone mentioned that. About 30%, and this climbs higher as people have the disease longer, are going to have comorbid depression. So addressing the depression. So that they're not having to deal with that as well as the pain. Lifetime prevalence, 74%. So if you're dealing with someone who, or in a population where this is prevalent, then screening for it. Prognosis comes and goes, waxes and wanes, worse sometimes, better than others. Fatigue generally persists. Next page, exercise programs seem to benefit pain and their function. Low impact activities seem to be best, things that don't aggravate the underlying pain. Okay. And exercise usually helps most things. It increases our natural endorphins, it helps us, it increases our ability to deal with stress. In terms of pharmacologic therapy, there's antidepressants. The one that is most, that have been looked at the most are the SNRIs, the old SNRs. Remember we talked about amitriptyline and, or the TCAs, the tricyclic antidepressants, and then also we'll see Cymbalta show up again, and milnacipran. So the SNRs seem to be better than the SSRIs, but if you had to use SSRIs, you can. But most of the benefit is seen with this other group. Anticonvulsants, so pregabalin and gabapentin, so Lyrica and Neurontin, and then cyclobenzaprine. Okay, so referrals, think about psychological referrals, so cognitive behavioral therapy, helping them to understand, gain insight, control. That's a big thing. If people feel like they have control over something that is causing them trouble, they usually do better as well. The medical referrals, rheumatologist. Sometimes these folks have it with other rheumatic diseases like RA. Can you imagine fibromyalgia and RA? Visitress, and now I don't remember what they are. Anybody remember? Physical therapy? Not physical therapy. Somebody look at it. Somebody Google it. Y'all are good at that. Y'all know how to do that. Somebody tell what a visitrist is. Psychiatrist, sleep specialist, pain management specialist. Okay, and the rest of that is a repeat. So complementary and alternative, in June there was a large study that came out about Tai Chi, and I put it at the end, we'll talk about that. Yoga also seems to be beneficial for these folks. Okay, just interrupt me when you find it. Okay, so let's talk about pharmacologic therapy.
Professor Latassi.
Yeah.
It just says it's a branch of medicine that aims to enhance and restore functional ability and quality of life in those with physical impairments or disability. And it's just like a combination of physical medicine and rehab.
They're MDs that did residencies in physical medicine.
Okay.
So they went to medical school.
Okay. Could you hear Kira? Did you hear? Okay, great. Thank you. I have not met any, but I don't practice in those areas, so very good. Okay, pharmacologic therapy. So the things to remember is, what is the particular symptom? Where are they having the most trouble? Is it pain, fatigue, the insomnia, the depression? Target those. And we'll point that out as we go through. Always looking at, like every time we talk about what are comorbid diseases that can be aggravated by what we're treating, also the adverse effect potential and that worsening underlying problems. What the patient will tolerate, how much is it going to cost them, will their insurance pay for it, are the last two. So initial therapy, the most effective drug is amitriptyline. We use low doses. We'll see this when we get to diabetes as well with neuropathies, is that we use much lower doses than what we use to treat depression. So you'll see here starting with as low as 5 to 10 milligrams. We always give it at night. It has a very long half-life. The thing that people will complain about the most are the anticholinergic effects. So dry mouth is a common, drowsiness, and a hangover effect, very common. That mental fogginess for several hours after they get up. The higher the dose you go, the worse they'll complain. And then increasing the dose until what you're targeting has improved. So usually in the 20 to 30 milligram range is common. Now for depression, we use 75 to 150, even up to 225. So this is really low compared. And we'll see that when we use it for pain, for neuropathies. Also, at low doses, the body seems to respond well with diminishing pain. So there's those anticholinergic side effects, the dry mouth and the constipation. Weight gain, grogginess, difficulty concentrating, that's that mental fogginess, more in the morning than it is throughout the day. Next page, dose may be limited, especially if you're dealing with older people and they are on other anticholinergics, they'll complain more. Another drug in that group, dizipramine, is also a tricyclic antidepressant, TCA. Has not been studied as much in fibromyalgia, but it has less anticholinergic effects. So it might be one to consider. An alternative to amitriptyline is cyclobenzaprine. This is a muscle relaxant, Flexeril, been around forever. It's unusual in that it has a structure very similar to the tricyclics, but it doesn't have any antidepressant activities. It does have those anticholinergic activities though. We use very low doses of them. It's a very sedating drug, as are most muscle relaxants. So you really have to warn people, don't take it in the morning, you'll go to sleep. Taking it at bedtime is almost always preferred. So they relax the muscles, and so that may be what is helpful for some patients. Under adverse drug reactions, anticholinergic. Think the tricyclics when you're thinking about what kinds of symptoms they cause. CNS depression, serotonin syndrome, so keep that in mind. People won't think about that. It's not one that readily comes to mind. So if you're using it with another antidepressant, that could be a problem. And then cardiac effects. The tricyclics, so remember this, one of the reasons why we don't use them is that in doses that we use and dispense, they can overdose on them. So they have lethal overdose consequences. Remember the SSRIs came about because they're effective, but they don't cause overdose lethal effects from an overdose. The TCAs do. The main problem in overdose is cardiac. So it's the heart often that will kill them, heart effects that will kill them in an overdose. So contraindications, don't use them within 14 days of an MAOI inhibitor. Hyperthyroidism, heart failure, arrhythmias, those would all go back to the cardiac effects of the drug. So hyperthyroidism, they are at risk for cardiac effects. So that's why that's in there. So the old SNRIs preferred, cyclobenzaprine if you can't tolerate those. The next would be use the newer generation SNRs like duloxetine. So these are most helpful for those who have severe fatigue. Remember, that's a predominant of this disease. So if you have somebody who's depressed and has the fatigue, this may be a good drug to think about for you. The problem with the TCAs in depression is getting the dose up high enough to treat the depression and the side effect potential. So while they are good in terms of pain, if you're going to treat depression, you may prefer to move on to Cymbalta instead. See what I'm saying? Okay. Mental fatigue, also responsive to duloxetine, but not general fatigue. What did I mean by that? Okay, I have to go back and look at why our stuff went on.
One of your learning objectives says state the symptoms that are most responsive to duloxetine.
I'll go back and clarify that. Because I put severe fatigue up there, but then I put general, it's not. So the mental may be the more. Let's see. Significantly reduces pain severity. And the good thing with this is sustainability. That's what you want to look at. And you want to look for studies where you've got long-term effects. So we know with Cymbalta, people can take it for long periods of time and there's no long-term consequences of that. So that's good because this is going to be a disease where you will treat them long-term. Best to give it in the morning. Start with low doses, that 20 to 30 milligrams a day, and 60 milligram is the recommended. So again, you're going to use lower than antidepressant doses to treat this. And now, if you're going to treat depression and the pain, you probably would have to go on up into that 60 to 120. Most common side effects, nausea, headache, dry mouth. Remember, of all the SNRIs, Cymbalta is the most well tolerated. Okay. Now, next page, milnacipran. What do you remember about it? It's an SNRI. How does it differ from, say, Cymbalta? Decreased cardiac effects. What is its most? Yes, blood pressure. So because you've got norepinephrine and serotonin, right? Milnacipran's, most of its effects are through what neurotransmitter? No, norepinephrine. Okay. So there's where your cardiac effects come from. So mostly we talked about blood pressure being the problem. So fatigue, pain, it's an alternative. I wouldn't say it's the one to go to. I'd use Cymbalta first. It's just well tolerated for the most part. Starting low, titrating up, add blood pressure, add higher doses to those commonly adverse effects. Same things you see again: nausea, headache, constipation. Anticonvulsants. So if you need pain, anticonvulsants usually are better. So gabapentin and pregabalin, those are going to be more the drugs you would go to for pain. When we get to diabetes, we'll see we use it for neuropathic pain. So if you can kind of link the two. Pregabalin is preferred over gabapentin. Also patients that have sleep disturbances. So we talked about this with the, what else do we use this for? In neuro. No, not insomnia. Seizures, we talked about them. So often people will take these at bedtime because of the fatigue or the drowsiness. So here we're going to use it to our benefit. So for sleep problems, we can do this. Again, therapeutic effects are sustainable for at least a year. Here you have a wide range to titrate. So that's good. Again, we start with low, but you can go up fairly high with this drug until you get benefit. You look at the very last, though, and we saw this the last time we talked about it, is adverse effects tend to cause a high percent of patients to withdraw. 25% withdrawal from a drug is high. Okay? So the reason they are getting off the drug, the dizziness, somnolence, dry mouth, weight gain, peripheral edema. Gabapentin is one that is an alternative. Here you've got to watch renal function, so if you're dealing with an older patient. Dizziness, sedation, lightheadedness, weight gain, similar. Most people tolerate gabapentin pretty well. Lyrica, what I've seen is those uncoordinated, dizzy complaints, gait disturbances. Under other information, duloxetine, pregabalin were superior in studies to milnacipran. Headache and nausea more likely with those two, with duloxetine and milnacipran. Diarrhea more likely with duloxetine, that's the serotonin component. Cognitive defects, weight gain more likely with pregabalin. It's more central. Prognosis, symptoms to continue throughout life. Again, they go up and down. People who are well educated in the disease and you're addressing the main problems either through therapy, through like Tai Chi or yoga and drugs, most of these people can lead very normal lives. And the depression, be able to work and do whatever they want is certainly within their reach. Sometimes you have to educate people as to that's what it can look like. Sometimes if they have lived with the disease long enough, they will not see themselves being anything more than what they are. With asthma, when I work with kids or with adults more with asthma, that was one of the things I always had to convince them of. You should expect to be asthma-free. A lot of them would tell me, well, I've grown up in a family of asthmatics, everybody wheezes, that's just normal. No, it's not normal. We can get you to the point where it is not what happens to you. So sometimes it's painting a picture for somebody. Here's where you can be. Here's what you can do. Here's how you can benefit from treatment. Okay, let's see, last page. Oh, let's see, prognosis, female, okay. So obesity, working on good nutrition. Again, you know nutrition, when you eat like crap, you feel like crap, right? Okay, so eating well, taking care of yourself, all those things are foundational to good health and also disease management. Depression, history of abuse, drug abuse, alcohol abuse, catastrophizing, what's that? Dim gave me a physical sign of what catastrophizing is. So catastrophizing is, oh my gosh, I failed that last exam. They're going to think I'm dumb. They're going to get rid of me. They're going to throw me out of school. I won't be able to pay back all this money I borrowed. I'll never get a job. That's catastrophizing. It's relatable. Not catastrophizing goes, okay, it's one test. I'm here, I'll make it. Okay, so that's catastrophizing. So mortality rates don't change, but increased risk of suicide. So that's something also, it's part of your depression monitoring, screening, treating, and making sure they're responding to the therapy. So you can use combination therapy. So what's nice here is that you've got drugs from different pharmacologic categories. So you've got SNRIs, you've got like pregabalin, anticonvulsants, and you've got like skeletal muscle relaxants. So you can, for people who don't respond or they're not getting or they can't tolerate the drug to maximum use, you can combine drugs. And there's some combinations listed down there for you. You never want to combine two antidepressants, okay, or two drugs from the same class. But they do here recommend a couple of things. One is that, look under the very first, low dose of an SSRI or an SNRI in the morning and a low dose of amitriptyline at night. Okay? So what they're doing is they're taking advantage of that sedating quality of the antidepressant at night, of the tricyclic. But they're using the other parts of the drug and how it works throughout the day. Using duloxetine in the morning with a low dose of an anticonvulsant at night. So pain, sleep, that would be an alternative. So if they couldn't tolerate the amitriptyline at night, the anticholinergic side effects, you could think about a low dose of pregabalin. In terms of pain medication, so when we're talking about pain, you don't hear us mostly not talking about any analgesic effect, right, or opioid. Opioids you want to avoid, except for one, tramadol. Non-steroidals, glucocorticoids, we're not going to use those. I mean, if you got episodic and you're treating something else, do that. But for the fibromyalgia pain itself, those are not recommended, with the exception of the tramadol. So if you look under that third bullet under examples of combination, tramadol has been used. It is an opioid-like drug, but it has other effects. It has some serotonin effects, and it's one of the drugs that people get into trouble with. Or you'll get a phone call from the pharmacist saying, "Okay, they're on an SSRI. You put them on tramadol. That's two serotonin-like drugs. Are you sure you want to do that?" So that's one to keep in mind. It's a little bit different. Non-steroidals for breakthrough or flares are certainly things that you could consider. But if you also ought to look for other sources of pain, because they could have pain from another disease or condition. Treating those, a peripheral neuropathy, treat that. An arthritis, treat that. Instead of looking for it all coming from the fibromyalgia. Non-adherence is high with this group. Some of it is just depression always decreases adherence. Some may be that they don't feel the drug is working, or they're not taking it enough to realize effects. So always assess non-adherence. Forgetfulness, if a lot of their it's depression or mental fatigue, it could be that is what's affecting their adherence. Let's see, we talked about treat other sources of pain. Next page, I put some more on there about the tramadol. It has a low potential for abuse. To me, it's good, it's powerful, short term. It will certainly do the trick. Let's see, we talked about don't use non-steroidals long term, glucocorticoids for this either. This talks about the SSRIs. They're just not as effective compared to the SNRIs. Complementary and alternative therapies, again, Tai Chi, yoga, acupuncture may help. Insufficient evidence for dietary interventions at this point. The meditative movements, that first is that Qi Gong. It's very similar to Tai Chi. I do not appreciate the differences, but they're a more holistic approach to meditation, spirituality, movement of the body. I put down the summary of a study that was done and published this year that looked at Tai Chi for fibromyalgia. And they found it was very effective, and the longer people did it, the more effective. So 24 weeks was more effective than 12 weeks. A year, it was more effective than 6 months. So you might consider recommending that to people. Anybody ever done Tai Chi? Some of you. We, at Family Medicine, we had a resident who was very good at it. And so on lunch breaks, he would line up the staff and they would do it. It was just so beautiful to watch. That's what struck me. And when I was in China, when we were in gardens, there were always the older people, especially if you were up early enough. They were everywhere. And you just to sit and watch, it's like ballet to me, the way they moved. So keep those in mind as well. Questions? Okay, so you know the drugs, just go back and apply them. And go back and look at those things that you've done before. I guarantee if you'll go back over it again, your brain will remember. Use those, practice that retrieval process we talked to. Go back and make yourself say it and then look at it and see if you retrieved it right. And your brain will pay more attention to it. All right, let's see. I will see you on Monday. We start endo. Let me say a couple of things about endo. It's packed, but I have tried to construct it so that most days you're not in class more than 6 hours. There's a couple where I couldn't avoid it. So there's some out of class exercises or self-studies. There is a lot of cases built in. To me, endo, the one thing you can start doing there is it's very integrative because it brings in cardiovascular, neurologic, many different diseases start to be tied to it, renal. So those cases are tied to graded activities. Do not skip them. You will miss points, okay? So I'll go over all that on Monday when we walk through it, but don't plan to miss. Okay. All right. I'll see you then. Have a good week.